Good afternoon. Good afternoon. My name is Caroline Trevithick. I'm the Chief Nurse and Deputy Chief Exec for the Leicester, Leicestershire and Rutland CCGs. We're here this afternoon to hear more about the Step Up to Great Mental Health consultation that we've been running. And we've got Helen Perfect with us. Helen's from the mental health team at Leicester Partnership Trust. And myself at the moment, and we may be joined by one of our consultant psychiatrists. So we're going to show a video just in terms of what we're consulting on at the moment, and that'll also show people how they can get involved with the consultation process, either by taking part in some of the workshops that we've got coming up over the next few weeks, or by taking part through a questionnaire. So if we can go straight to the video, that would be really good. Thank you.
We have a significant opportunity right now to enhance the quality of people's lives by investing in mental health services provided in Leicester, Leicestershire and Rutland. Our mental health heavily influences our whole health and well-being, and it's as important as our physical health. We at the NHS recognise this and are investing more in local services to dramatically improve care and treatment. We want to help everyone living locally to thrive and live the life they want. We've been working with individuals for some time now to really understand what they want in their mental health services. We've worked with people who've experienced our services, staff and stakeholders to develop key proposals that we want your views on. Our plan covers two key areas: investing in and improving services for people when their need is urgent and when they need planned care and treatment.
How can we make sure that we use our resources and our investment for the best needs of the whole population, and that we structure our services to meet service users' needs and carers' needs in the best possible way? We think we've done lots of good things around that, but we think we've got lots of ideas within this consultation that will make it stronger and a better service for people, and a more integrated service for people, an easier service to navigate, and there'll be better outcomes for people and their families.
When the need is urgent, people said they wanted an easier way of getting help at any time of the day or night, and they wanted to get this help quickly and directly. This feedback underpins our proposals for change. We want to deliver better advice and guidance, so when people are first looking for support or even just information, they can find it all in one place online. When individuals need more help or are in a crisis, we recognise it's important as a place they can contact 24 hours a day, 7 days a week, by phone or text. We want to introduce a new central access point for people so they can do this.
Patients have been able to call us directly if they were struggling without having to attend A&E. So therefore that's actually reduced the number of people going to A&E that could have access to mental health services without any other service having to refer them.
An important aspect of the central access point is the crisis service. This means people can get help directly without contacting their GP and get an assessment within 4 hours if the need is urgent, and within 24 if it's less urgent. Crisis cafes also offer urgent help. We have 3 already, and they provide a safe space for people to get help when they're experiencing a crisis. We want to increase the number to 25 and are asking where people want them located and what services they could provide.
The Crisis Cafe is a really important part of what we do to support people in the community with mental health issues. It's somewhere they can come where it's safe, it's a welcoming environment, and we help them in terms of looking at what is causing the problems. It may well be that there's a financial issue, the relationship issue, it may well be it's a mental health issue itself that's the problem, but a lot of the time people actually just need someone to talk through their issues, get the help that they need and meet other people.
We want to increase the mental health support in emergency services to better support individuals when incidents occur. We're proposing to expand our existing triage car service to work longer hours and cover both police and ambulance services. During the pandemic, we quickly set up the Mental Health Urgent Care Hub to provide more targeted support away from the emergency department. It's a space the emergency services, social care or other health professionals can refer into and offers people a rapid assessment and support. Through our proposals, we're looking to make the changes permanent. When people experience ill mental health, they may go to the hospital's emergency department for help. There's now extra expertise there 24 hours a day, 7 days a week in the emergency department. This is called the Acute Mental Health Liaison Service. It also helps people who are already on a hospital ward. Finally, there are individuals who are particularly vulnerable, who need mental health support urgently, but for various reasons don't access it. There are currently 3 teams working with vulnerable groups, including homeless people and individuals that present in the criminal justice system. We propose to bring these teams together into one dedicated service to help more vulnerable people access the care they need. So to improve mental health care for people who need urgent help, we want to provide self-help and guidance, further develop the central access point, create more and strengthen the role of crisis cafes and improve crisis services, expand the use of the triage car, introduce permanently a mental health urgent care hub and an acute mental health liaison service, join up services that support particularly vulnerable groups of individuals with mental health needs that do not access the support they need. The second key area is improving planned care and treatment. People told us they wanted as much care as possible to be provided near to where they live and be organised around their needs and the needs of their local community. We've listened to this feedback and developed the following proposals. We have a number of teams working separately, with some work being duplicated or triplicated, and long waits as people are passed between different teams. We want to bring these together into 8 new community treatment and recovery teams, working in local areas to support adults. They would work alongside an additional 8 teams who would focus on specific mental health needs of older people. These local teams will be supported, if needed, by other experts to provide more focused support. This includes help for women pre- and post-birth, and for people with complex personality disorder, also those with early signs of psychosis, difficulties with memory, and for individuals that have complex needs who will benefit from community-based mental health rehabilitation to support their recovery needs. So our plans are to work with local communities to provide better planned care and treatment, reduce waiting times for treatment and join up services to create a local seamless experience, improve support for individuals with personality disorder, improve services for people of work age and older people, expand perinatal services for the time immediately before and after birth, and develop a maternal outreach service. Improve the experience for people with potential psychosis, reduce the wait for a diagnosis of dementia, and provide rehabilitation support to help people recover from complex psychosis.
This is a once-in-a-generation opportunity for us to deliver the mental health services that people in Leicester, Leicestershire and Rutland truly deserve. Please take your time to have your say, whether you've used our services now or in the past, or simply know somebody that needs or relies on mental health services. We want to know what you think. Visit our website, complete a questionnaire and help make a difference. Step up to great mental health today.
Hi, good afternoon, everybody. So thank you for joining us. I see some people joined us as the video was playing there. My name is Caroline Trevithick. I'm the Chief Nurse and Deputy Chief Exec for the Leicestershire Clinical Commissioning Groups, and I'm going to try and organise us all this afternoon to make sure that people have got plenty of time to ask questions and make comments, etc. So we've seen the video that describes the services that we want to get people's views and consult on for mental health services across Leicester, Leicestershire and Rutland. And the rest of the session is really over to you to come back and if there's any questions or comments. I'm joined by Helen Perfect, who's from the mental health teams from Leicester Partnership Trust. And we've got a member of our comms team in the background. She's going to be making sure that she kind of checks any messages, etc., that are coming through. But if people want to kind of put the hand up, wave at me, a couple of you have got your videos on, so I can see you. If you want to pop something in the chat box, then please do. We're here to hear from you. So anybody want to step forward and ask anything? Okay. So I'm just getting a message from Joe behind the scenes. So just check. So that's what I'm doing, looking down. So yes, do you want to share the bullet point slide, Joe? That'd be helpful, just in case people miss things from the video. That's what she's asking me. So we're just going to get a change of screen here. There we go. So the slide that we can see at the moment, that's what we were talking about the planned care services. So this is the care that we can plan for. It's in the name, but we're trying to do a number of things to improve the experience and care of people from a planned perspective, covering all ages, including maternity as well. So is there anything anybody wants to comment on there? Joan, I think you've got your hand up. Welcome, you're from Breathing Space. It's great to see you. You just need to unmute, Joan. Let's see if I can do it for you.
Okay.
There we go.
Sorry, Caroline, I didn't have my hand up, but it all looked wonderful. I suppose my question, having worked in the therapy service in NHS, is in terms of how soon this would all be implemented and how funded, I think would be my question.
Okay, thank you. And we've also got one in the chat about who would be staffing the community treatment and recovery rooms. Helen, are you okay to take those two questions?
Sure, of course. Hi, everybody. Helen Perfect. I'm head of service for the Mental Health Director in Leicester Partnership Trust. So, Joan, the question was, when is it going to be implemented? And was it the funding question?
Yes, because I'm conscious, having worked in the NHS, that this is always an issue. And so, yeah, I suppose about in reality, how soon would these things be up and running?
Okay, so there is a very formal consultation timeline, and the consultation ends officially on the 15th of August. Obviously, the consultation is done, it's being led by the CCG, so our colleagues. So they're working with an organisation to ensure all of the feedback from all of the different consultation events, whether that's the things we've done like this, sort of virtual events, we're sort of getting written feedback. Certainly my teams, we're talking to patients who are already inpatients in our services through our sort of ward-based community team. So all of that information will be collected. There's high-level feedback coming back now already. And that's going to then be analysed and presented back, I believe, Caroline, to the CCG sort of, I think it's early to mid-October. And then the plan, well, once it's been through the official sort of governance routes, then we'll start the implementation plan to then look to start delivering the agreed changes, so based on the feedback, from April next year. So that it's not long in the grand scheme of things, really. In terms of investment, I think we've already been, it's already been identified, hasn't it, Caroline? I mean, the National Health Services, NHSEI, have already identified a significant investment for mental health services on the back of quite a number of documents. So there's been the Mental Health 5-year forward view, there has been the proposed changes and with regards to community mental health services. There's all of the work going on with regards to children and young people's services as well. So we've already got investment committed already this year. So we've had significant investment for our perinatal services. We've already had significant investment to develop and further expand our crisis teams. So the commitment's already there, which I think it's exciting. The outputs from the consultation will really help us decide what else we want to spend it on, and making sure that spending is in, develops the services we actually really need in Leicester, and Rutland.
And Joe, if I might add, thank you, Helen. It allows us to make sure that we're spending the money in the right place, because consulting with people tells us whether or not we've got it right. We've done a lot of work to build these proposals up with patients. But we can only do that development with a small group of people. So consultation allows us to go out and really test whether or not we've hit the mark right. And so having the funding to be able to do that, and the investment in mental health is tremendous. We've been trying to get it on an equal footing with physical health for a while now, and we're really starting to see the benefits of that investment coming in. So does that help?
Yes,
Yeah.
I think the proposals are great. Particularly joining up services, because that's always the difficulty of people sitting between gaps, and certainly that's our experience in receiving clients into breathing space. So it's really positive to see joined up services. I think that would make a lot of difference.
And Joe, what does Breathing Space focus on? It's not an organisation I'm familiar with, I'm ashamed to say.
Okay, so we operate from Melton Mowbray, and we have referrals from Latham House, where I used to head up the therapy service there. Okay. And we get the referrals, and people can now self-refer. Really, I set it up because we were conscious that people were falling through the gaps, and we felt if we could provide something while they were waiting to get into IAPT's, currently Vita Minds, where the waiting list is about 6 months at the moment, I believe. Then at least we would be supporting the NHS in terms of offering. We have both trained listeners in depression, anxiety and bereavement, and we also have counsellors with us on placements from Sherwood Institute and various places around, so we can provide both those things whilst waiting, or even sometimes people don't particularly need that much help, they just need somebody to talk to.
That's excellent, and particularly as we're coming out of COVID, those waiting lists, as you say, they're really difficult. So that's excellent. Thank you, Joan. Thank you for explaining that. Martin, I come to you. Your first question is, who will be staffing the new community and treatment recovery teams? So Helen?
So Martin, we've already got both teams. We've got community mental health teams already in various different places across the city and the county. We've also got additional resource in our outpatient services. So, and we have some smaller teams. So essentially, the teams will be coming together. So it will be the existing staff, but be working in a different way. In the new planned 8 planned care and treatment teams. So the staff's already there. It's just about adjusting that staff to provide that support. I mean, it's not just CPNs. CPNs are a part of the workforce, but we've got AHP, so we've got OTs, we've got access to speech and language therapy, we have psychology. The psychology team and the psychotherapy team sort of sit alongside, so that one of the plans would be then for those teams to merge together, so you're not having to sort of work between an outpatient team then be referred to psychology, but the team come together in a locality, in a place, and they are working together collectively. And obviously there'll be psychiatrists in there, there'll be junior doctors in training, etc. So rather than the sort of separate teams or professional based teams, the plan is these new planned care and treatment teams in these new 8 areas will be the full skill mix that's needed.
Okay, thanks, Helen. It sounds like it's important. I'm making assumptions, Martin, from what you put in that final point there, that you're supportive of it not just being CPNs, that we do need that multidisciplinary approach that Helen's just described, and that's important feedback for us. So if I've got that wrong, yeah, okay, yes, certainly, yes. So we're kind of on that chat. We'll take that feedback back about how important that is. I'll pick up your question about the consultation. Not sure what's happened if some of the Zoom consultation sessions have been cancelled, but we've had a programme running up until now. This is the last of the formal kind of general engagement events with the public that had been planned. But as Helen said, the consultation finishes on the 15th of August. And between now and the 15th of August, we've got workshops planned, but those workshops are subject specific, because obviously you've seen through the video and the slides that there's a lot of information here that we're trying to get across. So the targeted workshops are much more about people being able to focus down on specific areas. I'm not sure what those workshops are focusing on, but they're on our website, so we can point you to the website should that be needed. Okay,
well,
so
this is Martin speaking.
Hi, Martin.
Hi. Yeah, that talks about the workshops being targeted on specific issues, but it doesn't actually address my question about consultation being targeted to work with patients and carers.
So do you mean the consultation process that we're running, or consultations, patient consultations? Sorry, I'm just trying to work out where you're going to. I'm not 100% sure I understand.
Have you heard of the Patients and Carers Involvement Team at LPT?
I have, yes.
Are you aware that they were running Zoom-based consultations as part of all of this?
Okay. I know we've been working in partnership with the team in Leicester Partnership Trust to deliver those. Jo's just come online. I think Jo's going to help us out here because she's working really, really closely with that team.
Yeah, hi Martin, hi everybody else. Yeah, I am aware that they did actually get cancelled just because of low numbers, but what we're doing is we're offering our other CCG-led workshops, which are run in a very similar way, and they're still available. However, if you did still want to be involved on a one-to-one basis, we can absolutely do that, and we're offering that too. So if I just put in the chat box the details, then we can have a conversation, and if that's something you'd like to be part of, we can make sure you're involved.
It's not just about me, it's about when you do a consultation that's just open to the public as a general way, it isn't as targeted as if you're looking at a particular audience. So I think it would be good to have consultations that were targeted at, for instance, patients and carers, as well as ones that are targeted at other particular groups. And when you're dealing with such a large and diverse population, you need to have consultations that's targeted at lots of different groups, and particularly hard to reach groups. And having just a public, general, open to all thing isn't sufficient.
Absolutely, yeah. I mean, just to give you an idea, that the one that we've got on the 22nd, which is next Thursday, that one is for carers specifically. We've got the one on the following day, which is for students. So we do have a lot of other targeted groups that we're doing, and we're working with a lot of local organisations to help us to do that as well. But again, if we could have a conversation about it, I can share all of that with you, and then just, if there's any gaps, we'd love to hear about them and just see if we can fill them really.
Yeah,
well, I've identified a gap for you, and so far I haven't heard how you're going to fill it.
Which was the gap that you've...
Martin,
because the Zoom consultations run by the Patients and Carers Involvement Team were cancelled.
So we'll definitely have to take that back. We can't resolve that today, Martin. I think it's important for us to look at whether there is anything in its place that matches it like for like. Helen's confirmed with me that the Partnership Trust are also consulting directly with patients and carers through ward meetings. So people are actually using services at the moment are in place.
Ward meetings are for inpatients though. not
Yeah,
outpatients.
yeah, but
That's just
sorry,
one.
Helen.
That's just one example. Because we've got written communication, we've got the videos, Martin. What we're able to do, what we've been asked to do, is where we're working with patients at the moment. So staff have those direct conversations. So, for instance, one of the services I'm responsible for is our homeless service, and staff. We're actually having conversations with individuals who we meet through our sort of day-to-day contact, through you know, the sort of drop-in centres, etc. And we're talking to them, and then we're taking that written feedback or that verbal feedback and feeding that into the consultation. So it's not just inpatients. We're talking to people sort of face to face, through our community mental health teams, through teams like our perinatal teams. You know, if people want, the information's available in places like the mental health hub. So if they want to fill it in or talk to staff whilst they're waiting. So we're taking, I suppose, opportunity to try and ensure everybody who are patients or carers, you know, rather than just access via a Zoom or something like that, there's multiple ways that we can share the information, but actually most importantly, listen and get their feedback.
Thank you, Helen. Martin, Joe's also popped in the chat that if we're getting the feedback, which we obviously are from yourself, that those workshops would have been useful, so we can go back and reinstate them at a time that suits everybody.
Yeah, it's not true that no one had booked onto them. I had booked onto them.
Okay, right, and our apologies for that then, Martin. That you know, we were planning on running this session today with nobody on it, so I'm not really sure why that happened, that it got cancelled. So apologies for that. But we have got a variety of ways, as Helen's just described, about communicating this with different parts of our public, and it's one of the tests that we need to assure ourselves that we've done, that we've used every opportunity. And so we have been advised as prior to the consultation as to what we're doing, and we'll be tested on it afterwards. So so your feedback is really helpful to make sure that we don't wait till the end to look to see if we did it right. If we need something to change, we'll change it now. So yeah, so Joe will get onto that on Monday straight away. So thank you for that. Okay. Are there any other comments or questions that people like to raise? Joe, I know you're on screen again. Did you want to just put the acute slide up? We've got the planned care one. So just to remind people what some of the changes are around the crisis and urgent care. Oh, there we go. So just a little bit of a reminder there, if anyone needs one, just to ask anything. And remember that the website at the bottom there, www.greatmentalhealthllr.nhs.uk, that's where you can find lots of information if you're a reader and prefer to read about it, or if you want to share the information with some friends, colleagues, family, whoever that might be, point them in that direction, and it will it'll give loads of information, but also give you the opportunity to put comments back into the process, or even ask for somebody to have a telephone conversation with you if you'd rather do it by phone. So lots of ways to engage with us to feedback. Okay. Natalie, hello, welcome.
Hello, good afternoon, everybody. Just a quick question. I saw there you said you're going to be joining up to support vulnerable groups. I just wanted to find out, what support mechanisms do you have in place to support these vulnerable groups or community groups?
Yeah, thank you, Natalie. Really good question. I think it's one for Helen. It's very much of a service delivery question.
Yeah, that's fine. Hi, Natalie. Well, I suppose we've got a number of groups at the moment, and there are groups that, as well, that really are sort of on the periphery of services, so we have at the moment a liaison and diversion group. We have a sort of proactive and vulnerable group, a team. We've got the homeless team, and they're all managing and supporting lots of different vulnerabilities. So we've got, people who have been veterans. We've got people who have been on the receiving end of domestic abuse, the LGBTQ community. We've got the homeless team, people at risk of sort of criminal, who've been through the criminal justice system. So we've got lots of different teams working at lots of different touch points, but often what these individuals, either they're not getting the support or they're having to sort of tell their story and be assessed time and time again. And I think that's one of the challenges that patients, carers, service users are feeding back. It's not helpful. They're just bounced from service to service, whether that's between, social care, it's about access to the GPs, etc. So what we're trying to do, what the plan would be, is to understand what support people need, how we can better provide it, and how we can be more joined up. So one of the things that sits underneath this support for vulnerable groups is something we're calling a trusted assessment. So whoever sees you first has that conversation is assessing and understanding from that individual what their needs are, then that assessment is taken and therefore is passed on to the most appropriate sort of part of the service, who is then able to provide support, rather than what we have at the moment. You might present to A&E and they'll do an assessment and they'll say, well, actually you might need to go there, and then they'll do their assessment, and in the end people disengage and they stop, and then they present again and they're going through that assessment journey. So that's the sort of high level, I suppose, aspiration and vision behind this, and recognizing then it's about how we then go about and ensure those vulnerable groups are really catered for. So for one example, homeless services is at the moment only accessible in the city. Is this for me, it's an opportunity to think about how the mental health homeless services can actually provide that support across Leicestershire and Rutland.
Excellent. Thank you very much. Just one more question, just highlighting something that you said about notification. I just wanted to find out, is there something that we could actually, in regards to pregnancy, is there some type of notifications that can be put on maybe pregnancy records, just something like a visual aid so that patients don't have to keep repeating themselves? Maybe just so a midwife could see that and say, oh, okay, I know that this person has been referred previously by the mental health services.
Yeah, I think that's a really good point, Natalie, not having to go through everything at every time, that there's some kind of way of
like
doing
a sticker.
that. I think we've been bitten a bit with stickers in the
or
past.
Something.
But I know exactly what you mean. Just a way of making sure that it's at the forefront of people's minds when they're seeing that lady. So yeah, we'll feed that back into the consultation. I don't know what we might be able to do, but I think it's really helpful feedback. That's great. Okay, we've just been joined by somebody, and if I can work out my Zoom.
It's me, Bharti
Hi,
from Sanatan. Sorry, I had another meeting, so that just finished. So I apologize for being late.
That's okay. We've been having a bit of a chat about the services. We've seen the video, and if you haven't seen the video, the website that's on this slide at the moment at the bottom, that you can go there and have a look at it. But we're really just here to answer any questions or get any feedback, any views that you've got. The slide at the moment that's up is the services that we're consulting on around the acute services or the urgent care aspects. But we're also consulting on some of the more routine planned care services as well. So if there's anything that you'd like to talk to us about, then please do.
Basically, I think there are 2 or 3 little points, because I think it's the cultural aspect and the cultural needs of specific communities, which are sometimes sort of either overseen, and just not regarded as important, or, it's not always understood clearly. I come from an Asian community where I know mental health is a stigma across all communities, but the Asian communities have always been sort of prone to pointed at as as a community who looks after their own all the time. And this is not always the case. So obviously that is something that is a worry for me. And basically, how do we sort of, make their voice heard for the services they require? When we do consultations and things like that, unfortunately, because they have never been able to, this particular community, it's Hindu community I'm talking about, have not been able to highlight the needs that they require or what is available, they're not aware of it. It's very hard for them to put points forward on what they require. Obviously, they realize they have a mental health spectrum of either sort of very, very basic to could be really, extensive needs. But sometimes it's just like, oh no, what is out there? If we don't know what is out there, how can we ask for it? So that's the first thing. I do agree that, where people have tried, even I myself have tried to, apply for funding to actually support this kind of services that are specifically geared and made to cater for these particular communities. Unfortunately, somehow it's not always been successful. I haven't been successful in any mental health applications as yet. So that is obviously there is a gap or some kind of a requirement, because what we are actually probably saying or what the needs are, that is something that doesn't fit in the overall criteria. So the criteria needs to be actually changed or looked at and be a bit more flexible to the needs of those specific communities. I keep on coming back to it, but there is this gap. And so even though, I may be here and saying I'm from this community and I have come to this cause, unfortunately, the gap is still widening and it's not actually coming closer.
Okay. That's really, really helpful feedback in terms of the not just the consultation, but kind of in general terms about how we engage with certain specific communities and addressing the cultural needs of it. I know that the Partnership Trust has done a lot to try and engage with specific communities, and they've done a lot with women-only groups, etc., to ensure that we do that. We do need to make sure that we are getting that information out to the right people, because you're absolutely right. If we don't get the information out in a way that they understand, in a format that they understand, how on earth can we expect them to feed back to us? And I think we're probably at the beginning of doing that in any way or format. But I think that what we've learned over COVID and how we've engaged with local communities over testing and vaccination programs has meant that we've had to do it differently. So we've learned a lot over the last year about how we're doing that. And it's working with people like yourselves and communities themselves that can help us shape that in the right way. I think
sorry, can I just say a couple of them? So whenever there is either a national or even a local scheme that is geared towards mental health, I think the word mental, if you actually translate that, literally translate it, it just means crazy or, somebody who's a nutty person. And that is something I think, how we used to have the brainstorming and that's been taken out. I think this actually needs to be really looked at, the word mental. So I don't know, if you just say something with the mind, do we have sort of, mind, really? So I don't know. I don't have the word for it, but I know that the mental actual word is the word that is actually deterring a lot of people. Right, okay, so that is one thing. And I've also heard that there's going to be some kind of some sort of scheme where they're hoping to have something like a crazy cafe and things like that, or something, or is it
crisis cafe?
Crisis cafe.
Yeah.
Now, crisis is, it's like if it's going to be right to the end point when you really desperately need it. Well, I thought we were trying to actually even, stop getting to that stage. And we're sort of, an intervention sort of things where, before it gets to the crisis stage. So when you have crisis cafe, that word is something that our community will not literally relate to at all. First of all, there are very, very few people who probably, go to cafes from our communities. So these sort of, the terminology is something, if you're trying to, obviously there is high mental health in the BAME community. And if this wording is not right, then you're never going to reach out to the people.
Yeah. And no, this is absolutely why we're out here talking to people, because that's the kind of feedback that we want. So we'll take that back. We'll make sure that gets included in the feedback. And also your other comment about funding opportunities. Yes, we definitely need to do more to get, and we had a bit of a conversation about that earlier, to say that funding is coming in for, but mental health services. It is starting to be rebalanced against physical health, and so that is positive. But we've still got some way to go to make sure that we're using those funds in the right way. So thank you for that. I'm going to go to the chat now, because we've got a number of messages stacking up in the chat. So I think I'm going back to the right one. Yes. So back to Joan then. Can you say more about provision for the psychosis diagnosis and personality disorder support? So Helen, are you able to do that?
I can share what I know, Joan, if that's okay. And if there's anything more, or you've got lines of questioning that might be beyond me, then I will have to take that back if that's all right. With regards to the personality, improved support for individuals with personality disorder that's referenced, what that's trying to look at is recognizing that that's more about the sort of psychological interventions rather for people with personality disorder, rather than what we have now, which is often individuals sort of bounce between services, or they find, a bit like when I was describing the vulnerability pathway to Natalie, they sort of fall between, because it's about engagement, isn't it? So we've got a personality disorder lead, and what she's trying to do is ensure that we're much more sort of psychologically minded, that we're supporting people, that it's a pathway, that people will need sort of different levels of support depending on where they are, in terms of their life, things that things are going well, when things aren't going well, and that pathway sort of is understood collectively by the individuals who are supporting them, their support network as well. So if they need some intensive support, that can be provided, and then it can be stepped down when they don't. So it's that, for me, is very different from probably what people experience now, which is either something very sort of structured, or contained within a sort of CMHT, or nothing, because they're not able to access the services they need. So that's sort of in a nutshell what we're aspiring to do for personality disorders. Early intervention is, sorry, Jane.
Is it likely to be more local? Because I'm aware that sometimes from where we are, people have to travel to get the support, and that's not always possible. And I just wondered whether that will be centered in the psychological therapies in each base rather than more centralized.
Absolutely. And I think that's the message, Jane, that underpins our community and treatment and recovery teams, that they're place-based in the locality, that we don't have this sort of lots of little teams scattered around, and you have to be referred there or referred there, but actually in the place, where you live in your locality, you've got your community treatment team. They'll have access to, and the team will have the right psychologists, the right therapists, and they're supporting individuals rather than those individuals having to go out and seek support from other teams. So yes.
Very good. Yeah.
And then the early intervention in psychosis, and we've already got a long and sort of well-established peer team anyway, and they have evolved from being just a sort of 16 to 35 to becoming a sort of up to 65 team. So it's just building more on that, in line with, there's a lot of national direction with regards to early intervention in psychosis in terms of waiting times, so 2-week waits, about the psychological intervention you get, particularly the type of medication. But it's also going to be very much about stepping people back into community support, you know, so when their time with the team is done, they've still got that ongoing support. Might not be at the same level as intense, but actually they're continuing to get the support that they need. So again, it's more a sort of about placing the team, the peer team, within the sort of wider community pathway.
I think that would be really helpful. Thank you.
Thank you, Joan. Just picking up on the comments in the chat. So Martin, really helpful comments there in terms of information to feed into the consultation process. About in your first comment there, I'm just going to go straight to your second comment. I talk about getting information out. Yes, that's my. I'm afraid that, apologies for that. That's a bit my shortcut of working with communities to talk them through the information that we've got. You're right, quite right to pull me up on that. And what we do want to do is make sure that we're talking to people and listening to people, and not just putting information on websites or putting leaflets in places that people don't know where they are, or posters, etc. It's the conversations that are really important for that. So thank you for that. Natalie, going back to your point, inclusion also uses language barriers. Yes, definitely. And I see you've got your hand up, so I'm going to go straight to you now to ask you to come in with your point.
Thank you very much. Just going on from what Helen was saying, I just wanted to ask you a quick question. You know, in regards to clinicians, would there be continuation of carer with clinicians? So just, will the patient continue seeing the same person that they're always seeing? I just wanted to find out if there's going to be continuation, because that could pose, you know, an issue if you're seeing different people each time.
Yeah, I think that's the aspiration. Do you, in relation to patients now staying with the same clinicians as we potentially evolve our planned care, we're working on that at the moment, and where we will ensure people who have got support from regular clinicians, that will continue. That's obviously a lot easier to do in planned care when you're managing a sort of caseload and you've got your own sort of outpatient list or community list, etc. But yes, absolutely. One of the things that we have done, it probably doesn't reference it in the consultation, we've all got System 1 now, which is a new electronic patient record. It's used in GPs predominantly. It's used in the rest of LPT. Mental health services went live on System 1 last year in November. So that's a really good way of ensuring stories, people, you don't have to keep repeating, because you've got that, an individual's health record at a glance. So yes, in planned care, absolutely. But it's also about making sure that individual gets the right care with the right person at the right time. So if you do need access to sort of OT, within community, so that's an occupational therapist, then that person's available to you. Crisis in urgent care, very much that's, if someone's on shift, they'll be working. It's one of our challenges in the crisis team, is that continuity of care, and your patients are normally with us for a couple of weeks, so we try and schedule those visits and those interactions with the same person, so they're key worker. So yes, we will try, Natalie, absolutely, to ensure that continuity of care is considered and continues for individuals.
Thank you very much. Thank you.
Mute. I would unmute myself. Natalie, from a maternity perspective, that continuity of carer is something that we're working towards, and we've got a plan in place for that. And that's a very specific requirement that the government has given everybody to ensure that from a maternity perspective, that women get the same midwife throughout. So if we've got, linking it back to your point about, could we flag things with on people's notes, that it's absolutely important to make sure that for that point of the care anybody needs, if they're suffering from a mental health perspective, there's continuity of care for all aspects of their care as well. So yes, that's definitely something we're working on. Okay, so I've got something popped up. Continuity, Martin, you've said continuity of care has never been right. Community mental health teams used to include adult social care, then they did, then they didn't. Yes, currently they don't again. Yeah, and that connectivity across health and care is a basis of our ambition, definitely, to work that it's absolutely joined up with health and care at the level that our patients need them to be, our service users need them to be. You've said consultant psychiatrists used to work across inpatient and outpatient care, and then it was changed. So you see one psychiatrist on the ward, a different one on outpatients. Yes, and that talks to what Helen was trying to say about the fact that we need to get that right, because you need to have faith, you need to build a relationship, etc. It's really important. So we will take those comments and feed those back. So thank you for that. Okay, it's coming up to 3 o'clock. I'm conscious, I'm hoping that everyone's got plenty of water, because it's I'm sure people are warm. A significant problem in connecting adult social care and community mental health teams was that they had incompatible computer systems. Yes, and that's one of our successes across LLR at the moment, that we've started to, we've got computer systems that actually talk to each other. And it's taken so long. And I know that nurses, social workers, everybody, OTs, everybody have been really, really concerned about the fact that just having a computer system that underpins the care that they're trying to give, that allows people to talk to each other electronically, is so important. And yeah, that's one of our real bonuses that we've managed to do over the last few years, and something we haven't obviously shouted about. We ought to maybe share that, because I know that that's important to our service users as well, that they know that what they're saying to one team is shared and that they don't have to repeat it just because it's a different part of the system. That's great. We've had some fantastic comments and points made today. Every time I do one of these, I think it's that we get something different, and it just, for me, demonstrates the importance of coming out and talking to people and listening to people. We need to be in listening mode more often as an NHS. That's what we're trying to do. So Joe's put again in the chat that if there's anything that you want to pick up on the survey, then please do. There's an electronic version there and an easy read version, but you can always get hold of somebody to talk to about it if necessary. Natalie, you wanted to come back in.
Yes, sorry, just one more thing. Just regarding bereavement services, what type of services are we going to be providing for service users surrounding bereavement, as in and I'm talking about pregnancy, within pregnancy.
Okay. Yeah. So it linked to this consultation, we haven't got any information about that. But I think, in terms of what are we doing to outreach, I know that the trust, they've got bereavement teams now working. So anybody that has a bereavement in hospital, particularly, there's outreach to people in the community, and to make sure that they're supported and followed up. I'm not sure how much of that is if you don't hit the hospital. So if you have if there's anything that happens during a home birth or something like that, that may or may not be the case, but it ought to be. So the Trust UHL, that's Leicester Hospitals I'm talking about, UHL, they do have those bereavement nurses, and bereavement support is definitely something that I know that they touch with. Helen's just sent me a little note. Maternal mental health will also support those mothers as a group as well, because it's really, really important that anybody who's been through a pregnancy and has a bereavement, you know, gets that support that they need going forward. So yes, not something we're consulting on, but there is information out there for that, actually.
Perfect. Thank you very much.
Thank you. Okay. So if everybody's comfortable, Joe's put the final slide up, a little bit of a prompt for me. Oh, right, here we go. We've got another comment in the chat. Keeping me on my toes, looking at different places. Significant problem in having psychiatrists follow you between inpatient and outpatient care is if you move between city and county, and it's the management making decisions about efficiency of service. So they impose boundaries, so staff are assigned to see patients only from a certain locality, so can't follow a patient if the patient moves house. Staff are assigned based on what service you first encounter. So if you're an inpatient initially, your clinicians can't follow you when you leave the ward and become an outpatient. Okay, it's an interesting point there, Martin, that you raised, because a lot of our services, we're trying to get rid of the city-county division, but what we are trying to make sure is that it happens at a much more local level, so services are provided locally, and I think that's great if you stay in your house and you don't move. But I think that's a really interesting point that you raise about what happens if you move within the Leicester, Leicestershire and Rutland boundaries. What could we do to make sure there's continuity of care in that instance? And I'm not sure I know the answer to that, and I think that's something that we need to take away and reflect on, that when people have engaged and developed those real good partnerships with their clinicians, and then they need to move, how do we resolve that? I think that's a really good point. So thank you for raising that. And I think, and Helen's already talked about the fact that we're trying to improve that continuity between acute and planned care from a clinician perspective. So yes, good. Thank you, Joe. Yes, we'll take all of this back. So I'm going to close the meeting there then and say thank you to everybody for joining and taking part and making this a really good two-way conversation. It's been fantastic to meet you all and hear from you. If anybody does need any support from what we've been talking about today, those access lines are available for you to take up, because obviously talking about mental health services, sometimes you might need to talk to somebody afterwards. So we've got those helplines available should anybody need it. And a reminder again, if anybody wants any other information on the consultation that we're leading, our website is there at the bottom. So thank you, Helen, for helping me out with the questions, and Joe, really, really helpful support there. I wouldn't be able to do it without the two of you. And thank you everybody for joining us today.
Can I just ask, you know, the contacts and things that would just come up, will all those be sent to us on our emails by any chance?
Joe, those contacts that you put up, the support lines, they're available on our website, aren't they?
Yeah, they are on our website, but if you're struggling and you'd rather us send them to you, if you're happy for me to have your details, I can send them out to you. That's not a problem.
Fantastic. I'll just put my details on, Joe.
I can see it actually, so I'll just make a note, but that's absolutely fine. I can send those out to you.
Excellent. Thank you, Joe.
Okay.
Lovely. Okay, well, enjoy the rest of your weekend, everybody, and thank you for taking the time to be with us today. Okay, thanks.
Take care.
Bye-bye.
Bye.
Just the three of us?
I'll just stop the recording.